It's a real treat for me to be able to connect with all of you. Seeing so many familiar faces as well tonight. So thank you for being here. And so Betty had asked me to speak about the new BTK inhibitors. And so I'll take this opportunity tonight to give you an overview of the work that we've been doing with Ibrutinib, but also to tell you a little bit about the new BTK inhibitors who we're hearing now more and more about. Some new trials have just been recently been announced. So let's just go to the next slide here. These are my disclosures. So I think it's important for folks to recognize the complexity of Waldenstrom's. You could be seeing patients in a clinic on one day and not see, even after a full day of clinic, not see two people present the same exact way. And so I hope you can see my pointer. But for most patients, the disease is centered in the bone marrow, I think as many of you know. As a result, patients often become anemic. And the anemia is very complicated because it can also be mediated by iron deficiency, because the Waldenstrom cells make this very interesting protein called hepcidin. And we discovered this. And what hepcidin actually does is it actually causes the gut to not absorb iron. And it also forces iron into macrophages and other cells, taking it away from red blood cells. So as a result, the patient can become iron deficient anemic. And so it's always important, if you're seeing somebody with anemia, to make sure that you've checked their iron levels, because if they're low, you can often give intravenous iron to help get those red blood cell count up. Now, the Waldenstrom cells, I think all of you know, makes IgM. If you make too much of it, you can end up with hyperviscosity syndrome. And this can lead to nosebleeds and headaches and problems with the vision. But that IgM can also cause other problems. It can bind to red blood cells and cause cold agglutinemia. So it causes the red blood cells to lyse, to burst. It can precipitate under cold conditions and block our blood vessels. It can attack the nerves and cause neuropathy. So it's important to just recognize that there are many different ways the disease can manifest itself. And as a result, you really have to think about how you're going to use your therapeutics. If you have somebody presenting with a particular problem, you want to be able to target your therapeutics because of that problem. Lymph node involvement is unusual at time of diagnosis, but when patients relapse, it's very common. And more towards the later stage of disease, you can also see infiltration of the brain and the spinal cord, and this is called Bing-Neill syndrome. This used to be extremely difficult to treat. Now I'll tell you, because of Ibrutinib, extremely easy to treat. So this is how things have changed in a very short period of time. Now, this, as you know, Waldenstrom is a disease that we treat with Rituxan, because the target for rituximab, CD20, is very strongly expressed in Waldenstrom. When you give Rituxan by itself, about 30 to 40% of the patients actually respond. You never see a complete response, and usually the benefit lasts for 1 to 2 years, which is why we've been interested in combining Rituxan with other therapeutics to increase its efficacy. And the more successful combinations have been either using bortezomib, the proteasome inhibitors, or bendamustine with Rituxan. And as a result, our response rates are up to 90%. Almost never again do we see complete responses. And you're going to hear me say this over and over. It's very hard to get a Waldenstrom patient into a complete remission. And this may have to do with the underlying biology. But this combination can still get patients, remissions from 4 to 6 years in the frontline setting. So this is why we tend to use combination therapy and not single agent Rituxan in the majority of patients. Now, you would think that this is good enough and we should just call it a day. Well, it isn't, because each one of these therapeutics has some problems with it. And as a result, it pushes us to do even better. I think everyone recognizes that Rituxan causes the IgM flare. So you give the Rituxan, it can actually spur the cells to make more IgM. And as a result, if you have somebody who has a high IgM level, this will prompt patients into hyperviscosity crisis, or it'll make any of those things that we just talked about that is related to IgM, the neuropathy, the cold agglutinins, the cryoglobulins worse. I also have to say that if you use Rituxan too much, you can also destroy the cells that make the good antibodies. And as a result, patients can become what we call hypogammaglobulinic. It means their immunoglobulin levels become decreased and they end up with sinus and bronchial infections. And sometimes we have to replace that, give patients back good antibodies. And then there's the issue of intolerance. About 10 to 15% of patients will become anemic, will become allergic to Rituxan with prolonged use. So this is why, looking after new drugs is important. Fludarabine, big problem with fludarabine was that we were seeing a lot of patients convert to aggressive lymphomas. And so the field has really backed away from that. With bendamustine, we do see acute leukemia or myelodysplasia, which is a precursor to acute leukemia, in a small number of patients, about 5 to 8%, but it's not zero. We, as a result, tend to use less bendamustine than we used to. We do 4 cycles, not 6, to decrease that risk. And bortezomib, which is a very good drug, we see a lot of neuropathy and a lot of discontinuation because of neuropathy, which is why we're working on 2nd and 3rd generation proteasome inhibitors. And you may have heard, Jorge speak about our ixazomib study, which has shown less neuropathy, and it's an orally available proteasome inhibitor. So we are innovating around the use of better proteasome inhibitors as well. Now, all of us, I think, on this call recognize that one of the important discoveries in this disease was the discovery of the mutation in MYD88. This is a mutation that we found because of genome sequencing, and 95 to 97% of all patients with Waldenström have this mutation. So it helps us distinguish somebody who has Waldenström from other things that can make IgM. So it's a very good diagnostic tool. And, when you're getting worked up for Waldenström, it's important to have your MYD88 status. Now, the gentleman that I'm showing you here, Guang Yang, is probably the one we should give the greatest amount of credit to, because single-handedly in our lab, he's been directing all the work that has been important in understanding how MYD88 works. And so just to tell you a little bit about MYD88, this is actually a protein which signals for different viruses, bacteria that come in contact with these receptors called toll receptors. So, our immune cells have these antennas, and they're always looking for targets, infectious targets. And these are the TLRs that you see here. And so when they come across something that is foreign and looks like a pathogen, they then turn on MYD88. This is what they're supposed to do normally. And MYD88 is supposed to cause the cell to sound off, its alarm system and start growing and secreting things that then call the other immune cells, into order. Now, in Waldenström's, what's happened here is that MYD88 becomes mutated, and it turns on the whole system. So it doesn't need any more, a pathogen to come along and stimulate MYD88 to turn on. It's like a switch that's broken, but it's broken on the on position because of the mutation. And as a result, it's giving these growth and, survival signals. And what we discovered in our laboratory was that Bruton's tyrosine kinase, BTK, which is the target of Ibrutinib and all the other BTK inhibitors I'll talk about, is actually recruited into this complex. And through that, it's able to turn on all the machinery. Now, this story has become more complicated because MYD88 is like an octopus. It not only turns on this pathway by BTK, but it also turns on this pathway by Iraq, which is another molecule that also signals in the same pathway. It also turns on this molecule called HCK, and this was discovered in our laboratory, which in turn turns on all these other growth and survival pathways, including BTK. And most recently, we just discovered that it also turns on this other pathway, which is what we call the BCR pathway, mediated by this molecule called SEEK. Now, what I'm trying to tell you here is it's an octopus. When we use a BTK inhibitor, like Ibrutinib or Zanubrutinib, we're actually knocking off this molecule here, BTK, and it also has some efficacy against HCK. But look at all the other things that we can't shut down, which is why we're not seeing complete responses with these BTK inhibitors. And knowing these pathways is so important to us because we can start making drugs against these other, important molecules, and even combining inhibitors that target Iraq. We've made one. We made an inhibitor against HCK that's very potent. We have inhibitors against SEEK. And so by combining these now with Ibrutinib, we have the opportunity to really shut down in a more global way this signaling that's triggered by MYD88. So think of it as, you got a very complicated electrical diagram and you're trying to shut down all these circuits in order to cause the cell to stop growing. And that's really what we do, in our laboratory. We're basically electricians just trying to find the circuits and then figure out ways to shut things down. But we got to give Dr. Yang a lot of credit because he's really been very important in driving this progress forward. Now, let me go on and talk to you about the next mutation, CXCR4. You probably have heard all about this. This was also discovered in our laboratory, thanks to work that's been done by Dr. Zachary Hunter. He used our whole genome sequencing work and was able to discover this mutation. And so this is an interesting mutation because it's basically a receptor, a receiver, and it's supposed to tell the cell to go to the bone marrow. And the bone marrow actually makes proteins that actually the receiver picks up on and then homes in towards the bone marrow, which is why Waldenstrom's is a bone marrow disease. But when you have the mutation, the antenna here is stuck in the on position and it continues to signal. And the signaling that it creates actually causes drug resistance, which is why we've been studying this mutation in the context of drug resistance as opposed to growth and survival. So given these revelations, we were interested in doing a trial of Ibrutinib. And I'm going to update you on this pivotal trial. This is the trial that actually led to the approval of Ibrutinib in the US, Canada, as well as in Europe. And this was done with my colleagues, Dr. Advani at Stanford and Dr. Palumba at Memorial Sloan. And these were all patients who either had their disease relapse, it came back, or it was refractory, meaning it didn't respond to the prior therapy. In fact, 40% of the patients were refractory. And that's really not a good thing. When you have somebody who's refractory, it means their disease is really tough. And so we gave them Ibrutinib at 420 milligrams a day. And as part of the trial, we checked their MYD88 and CXCR4 mutation status to see what impact these mutations would have on the outcome of their treatment. So this has just been updated, and I just want to give you this data. The follow-up now is 5 years average. Some of the patients have been on Ibrutinib now 8 years, and the overall response rate is 90%. 80% of the patients had a major response, and what we call VGPR, very good partial response, 90% reduction, 30%. No CRs, again, no complete remissions. Now, if you look at how somebody's genetics looked, it makes a big difference. If you have no MYD88 mutation, no real response. If you have a MYD88 mutation, alone, great response. If you have both mutations, it's slightly less, and particularly those deep responses, the VGPRs, the 90% reduction in disease burden. Look at this, 47% versus 9%. Big difference if you have both mutations. And it also takes longer to respond, about 5 months versus 2 months. So it's about a 3-month lag if you have both mutations to get into a deep response. So having your genomics tested and knowing your genomics would help you understand your course, with a BTK inhibitor. And I will talk a little bit about what we're doing with this information, how we're actually now have treatments against CXCR4 that we're looking to advance. I also have to tell you that when you take Ibrutinib, your chances of staying in a remission in 5 years are pretty darn good. It's about 54%, and survival is 87% at 5 years for this, heavily pretreated population of patients. But if you had the MYD88 only mutation, 75% were still in a remission at 5 years. If you had both, it was 4 years. And if you had no MYD88 mutation, the patients progressed quicker. So this tells us how we once again can have the mutations help us in terms of understanding how long the response to Ibrutinib may last. Now, with the updated study, we also found that the atrial fibrillation rate went up to about 12.7%, but almost all the patients stayed on Ibrutinib with medical management, so it didn't affect the ability of the patient to continue treatment. Now, there's another study that I want to just talk a little bit about. This is called the INNOVATE study. Actually, I think there were some Canadian patients on this study. This is where patients got Ibrutinib and Rituxan, or they got Rituxan alone and a placebo. And when they got both drugs, they had a better response than Rituxan alone. But if you look at here and just concentrate on this, if they had only the MYD88 mutation, they did better. Their major response rate was better than if they had both mutations. It was less major responses. The same exact story that I just told you with Ibrutinib alone. In fact, the response rates are about the same. So I don't think the Rituxan's really adding much, except that it does cause the responses to occur sooner by adding Rituxan if you have MYD88 and CXCR4 together. What they also saw in this trial was that the patients that had MYD88 and CXCR4 together also progressed sooner. So basically a validation of exactly what we saw with Ibrutinib alone. Now, there are a number of other BTK inhibitors that are now being clinically tested in Waldenstrom. I'm going to talk a little bit about these, and these are what we call kinome plots. It's very interesting because I think even as a lay audience, we can understand how these things work, because these are all different targets that the drug goes after. This is for Ibrutinib. You see all the little blotches, it means that it actually attacks those kinase proteins. With acalabrutinib, you see a fewer ones, right, compared to Ibrutinib. With zanubrutinib, you see fewer ones than Ibrutinib. With tirabrutinib, even fewer. Everybody see the little blotch differences? It's like a Rorschach test. So, except what this means is that these BTK inhibitors would be expected to have more targeted effect, that they don't have off-target effects. Now, that could be good and bad, because some of the targets that Ibrutinib covers, like HCK, is good because, MYD88 turns it on, we want to shut it off. But there could be other targets that can give side effects, which is why a lot of people have been looking at these other BTK inhibitors to see if there's any side effect differences in particular. Let me show you these trials. This is the trial by Dr. Roger Owen of acalabrutinib. This is approved in the United States for the treatment of mantle cell lymphoma. The response rates, and don't even bother looking at this side, are the same as Ibrutinib. Same exact response rates. At 2 years, 90% of the patients had no progression of their disease if they were not previously treated, or 82% if they were previously treated. I will say not too far off from Ibrutinib, so almost the same as Ibrutinib. The follow-up was much shorter than Ibrutinib that I just showed you. It was only a little over 2 years' time. And acalabrutinib is given twice a day. You have to take it 100 milligrams twice a day, whereas Ibrutinib is once a day. So that's the key difference there. Side effect profile. You get headaches in the first few months with acalabrutinib, and their atrial fibrillation rate is lower, but it's at roughly 2 years' time, which is the same atrial fibrillation rate we had with ibrutinib. So the follow-up is still a little too short for us to tell you that it's going to have less atrial fibrillation associated with acalabrutinib. Now, zanubrutinib. This is the other very new and exciting BTK inhibitor. This was a study that started in Australia, and then other centers became involved, and I'm pretty sure in Canada as well. Response rates, the same as ibrutinib, except they get deeper responses. They've reported more VGPRs than what we saw with ibrutinib at this point in time. Progression-free survival means the time that the disease is kept in check, almost identical with ibrutinib at this time. So the folks that actually make zanubrutinib, BeiGene, decided that it was time to actually test zanubrutinib against ibrutinib. So this trial was just announced, and if there's any big news to share with you in 2020, it's this trial here, which is called the ASPEN trial. Now, mind you, the follow-up is short. It's 19 months, okay? I showed you ibrutinib's data was 59 months. Here, this is 19 months. They ended up, giving patients in the first cohort either zanubrutinib twice a day, 160 milligrams twice a day. And the reason why it's twice a day is because when they were giving it once a day, there was a lot more toxicity. So they settled on giving it twice a day. Or they were giving ibrutinib once a day. There was another cohort which gave it to people without the MYD88 mutation. I won't talk about that because, quite honestly, I'm not sure I believe that this study was done correctly, because the testing that they used to pick up the MYD88 mutation may have introduced a lot of MYD88 mutated patients in this arm. So this is yet to be published, whereas this one did get published just in the last few days. So I want to share with you the data for this head-to-head trial of zanubrutinib versus ibrutinib. Their primary objective was actually interesting. They wanted to see if zanubrutinib produced more VGPRs and CRs than ibrutinib. Fair enough. The population of patients was relatively balanced. There were just slightly more older people in the zanubrutinib study. No offense to anyone over 75, they termed it older. There were slightly more anemic patients also in the zanubrutinib arm. Now, what they showed was there were more VGPRs with zanubrutinib, 28% versus 19% for ibrutinib, but it wasn't statistically significant at this point. That what we call p-value, which is the test of significance, means that this could have been a random difference. And so, this didn't meet the primary endpoint for the study. However, when they reanalyzed the data with a more recent cutoff date of January 2020, not the August 2019 date that they did, at this point it was significant. It was 30% versus 18%. Now, the big criticism here is, what does VGPR mean? Does it mean you're going to be in a remission longer? We don't know. Does it mean that your disease is going to be, more ameliorated? We don't know. Which is why, this VGPR, a lot of people have criticized as being the right endpoint for this trial. The right endpoint that a lot of people feel should have been the side effect profile. This should have been what they call a non-inferiority study, where instead of trying to compare a variable that we don't really know what it means, it would have been better to just compare side effect profile and see if you can win on that. And had they done that, this would have been a different study, because they had a better side effect profile overall. There was less atrial fibrillation, 15% versus 2%, less diarrhea, although I really don't see ibrutinib being a drug that produces diarrhea, but nonetheless, for all grades, there was less bleeding, but conversely, there was more neutropenia. This is when the white blood count gets knocked down, A lot more of it was seen with zanubrutinib than with ibrutinib. So as a result, it's a yin and a yang, that you've got some good things like atrial fibrillation that's less, but you have a little bit more neutropenia here. I think this is still a very instructive study. I really do hope the drug does get ultimately approved, because it's nice to have other BTK inhibitors in case you want to switch over if somebody's having side effects. Or if you have somebody at high risk with atrial fibrillation, you have the ability to put them on zanubrutinib and not risk the atrial fibrillation. And if you have somebody who has an IgM-driven problem like neuropathy, maybe it is good to have more reduction in the IgM, as was the case, with zanubrutinib. So I do think there are going to be, situations that we're going to be able to use zanubrutinib in preference to ibrutinib, which is why I think trials like this are very, very critical. I also want to talk about some other BTK inhibitors just briefly. These are what we call non-covalent BTK inhibitors. So the difference between covalent and non-covalent. Covalent means that when a drug like ibrutinib, acalabrutinib, zanubrutinib, they're all considered covalent inhibitors. When it binds to BTK, it's bound for good. It sticks. It's like super glue. It's there, it's done. So the drug just has to get into the cell, and then the bonding has happened. Non-covalent BTK inhibitors, on the other hand, will stick to BTK, but they will unstick if there isn't enough drug around. So in order for the non-covalent BTK inhibitor to work, there always has to be circulating drug around. Now, you may say, well, why do you even develop a drug like this? Well, there could be differences in side effect profile, but also these non-covalent BTK inhibitors stick to a different part of BTK. And when patients become resistant to covalent inhibitors, they all become resistant, the whole class, because of a mutation in BTK. So this is why these non-covalent ones are being developed, to see if we can overcome resistance when and if it develops to ibrutinib and acala and zanubrutinib. Okay, now to get on to the fun part of the talk, because whenever you find a drug that works, you want to try to make it work better. And this is where we've been really trying to be innovative in terms of advancing BTK inhibitors in Waldenstrom. And so the work that we've been doing recently has been to use a CXCR4 inhibitor in patients who have mediated in CXCR4. This is a trial which we have ended now. It was a phase 1 trial of ulocuplimab. That's what the antibody is called. We ended it because Bristol Myers Squibb decided to discontinue developing ulocuplimab. But we learned a lot in this trial. We gave the drug for a total of 6 months, and then it stopped, and we continued on the ibrutinib. The patients were getting both ibrutinib and ulo for 6 months, and then the ibrutinib was continued on indefinitely as long as the patient was responding. This is going to be a very positive trial. It's going to prove to us that inhibiting CXCR4 is a great thing, because all these patients had deep responses, which we wouldn't have expected otherwise, and they all responded very quickly. So the concept of targeting CXCR4 is proven, I think, in this study. Now, the successor to this study is even more interesting, because it's a successor using a drug called movarexafor, which is an oral inhibitor. So instead of coming to the hospital to get the antibody, like Rituxan is an antibody, you would just be prescribed ibrutinib, and you would be prescribed movarexafor if you have both mutations, and you'd go home. And this is actually made so that you only need to be dosed once a day with movarexafor. And so we're very excited about this trial. We just opened it. So if there are patients in Canada who have both the MYD88 and CXCR4 mutation, this would be an ideal study to consider being on. Assuming you can cross the border, or we can let you back in Canada after you crossed it. So keep that in mind. But I'm really excited about this study. I think it's going to be a very, very innovative study. We have a lot to learn from this. Now, you probably recognize this face, Jorge Castillo, my colleague and friend. So years ago, we showed that this drug, venetoclax, potentiated how ibrutinib worked. We were the first to actually publish that, and now it's become a very important story in CLL and mantle cell lymphoma, where the combination of the two drugs together has resulted in very deep responses in patients. And in fact, such so that people are even stopping the therapy after a certain period of time. So we just opened this trial. We're combining ibrutinib and venetoclax. This is for people who have not been previously treated. And so basically it's a 2-year program. You take the ibrutinib for 1 month, we add the venetoclax the second month, we dose escalate it the second month, and then you're on the two together, 22 months, and then we stop everything. And then we see how you do. So instead of being on ibrutinib indefinitely, this has the advantage of being a definitive duration therapy. Quite honestly, just seeing the biology behind this, we're extremely excited. If there's one area that I think, will help us innovate in this disease, it's this combination. So I just want to conclude. I want to show you 2 algorithms. The first one is for people who have not been treated previously. The second one is for people who have relapsed. And this just got published in Journal of Clinical Oncology. It's the top journal in oncology. And we learned a lot from, the use of the genomics. And so it is possible now to have somebody's genomic status and to make very informed decisions about how to treat a patient. If they have only MYD88 mutation and they haven't been treated before, of course you want to prioritize a BTK inhibitor by itself, because this is giving us very long-term responses. And we don't have to worry about secondary cancers or neuropathy or other problems. If you have both mutations, then we have to be a little bit. We have to pause for a second and just say, do we need a rapid response? Because usually when you have both mutations, this is going to be people that have hyperviscosity syndrome. And so if you need a rapid response, we don't want to sit around and wait for ibrutinib to work, in 6 months' time. This is why we would give bendamustine or a proteasome inhibitor. But if we're not in a rapid response, then why not give ibrutinib plus Rituxan, to help accelerate the response? And the real problem is patients who have no MYD88 mutation. We actually were able to discover the mutations that drive this. We just don't have any therapy right now. And BTK inhibitors don't work if you don't have a MYD88 mutation. So we tend to prioritize bendamustine or proteasome inhibitors. Keep in mind that if your IgM is above 4,000, I think in Canada you say 40, you should not be getting Rituxan because it can cause a flare. You can get other therapies or get plasmapheresis to get the IgM down before you see Rituxan. If you have a lot of big lymph nodes, bendamustine is better. If you have amyloid, which is a protein that can cause kidney problems and heart problems and neuropathy, then we tend to use a proteasome inhibitor. And we do consider maintenance Rituxan in patients that respond to a Rituxan-based therapy. In previously treated patients, we'll use the same algorithm, except we will always prioritize a BTK inhibitor on first relapse if the patient hasn't seen it. And now after ibrutinib, we are using venetoclax. So I just want you to know that it's a very, 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 very active drug. And if you've seen ibrutinib and your disease is progressing, venetoclax would be a good option. Otherwise, the algorithm is the same. I will just only mention auto transplant. We consider it in people that have had multiple relapses, but you have to still be responsive to chemotherapy before we consider it. And now I will give you the last slide, which is going to be the most challenging, which is we have a lot of BTK inhibitors. How do you choose them? Well, I think availability is perhaps the first one. Whether it's available in Canada or not, at this point in time would be important to consider. Compliance, taking a drug once a day like ibrutinib versus twice a day for zanubrutinib or for acalabrutinib, is a concern for a lot of clinicians, particularly in older patients, because the compliance, meaning the patient, being able to remember to take the drug twice a day versus once a day, becomes a concern. Need for deeper IgM responses. So if you have hyperviscosity or you have neuropathy because of IgM or any of those other problems with IgM, well, maybe zanubrutinib may be better to get you into a deeper, IgM response. I think that would be particularly true for IgM neuropathy, where the less IgM, the better. Experience in certain morbidities, like if you have Bing-Neel syndrome, if the disease is in the brain, we know ibrutinib gets there. We don't have any data right now on zanubrutinib or acalabrutinib. Toxicity profile. If you're at risk for atrial fibrillation, you've had atrial fibrillation before, let's say, then maybe a zanubrutinib would be better for you than an ibrutinib. And don't hold your breath about cost. They all cost the same. Unfortunately, we were all hoping that, Zanu would be less. That's not the case at all. And here in the US, copays are very important. So unfortunately, I don't see any relief there. And with that, I'm going to conclude and want to thank you all for the opportunity to give you this update, and happy to take any questions.
Hello?
Questions?
Yeah.
Lawrence, I see you.
Yeah. Hi. Okay. Hi, Steve. Nice for you to come on, Dr. Treon, for us Canadians at a time that we're watching hockey now, or some of us anyway. My question to you is that for my particular circumstances, for about 7-8 years now, I'm on a watch and wait. I've never been treated. I'm asymptomatic. All my blood tests have always been good. The only thing is my IgM level has always been between, these are the Canadian numbers, between 19 and 22. So it's always been within that range. But all the other blood tests are great. The oncologist seems to think that I've just plateaued. And I guess my question to you is that with a like a high IgM level not being 0 to 3, it's at 20, but it's been at 20 for the last 5 years, but everything else is fine with me. Is this something that I could have for another 10 years, that it always stays that as long as I'm doing my best to take care of myself? Or like from your experiences, are there some people in the watch and wait have never been treated, but their IgM level is high?
Well, I mean, 2000 is about average. So I think in some of the series that we've published, somewhere between 2,000 and 3,000 is the average. High for us probably is 5,000 and above, so 50 and above. And to answer your question, we do have patients who have the diagnosis, but who don't progress for many years. And and so what those other factors are that then contributes to a patient progressing are some of the things that we're studying. Sometimes it can be an infection that comes along and it just triggers, the disease. Those are the kind of triggers that we're always interested in finding out. And it could be that in your case, it could be your immune system, has caught up with Waldenstrom and has kept it there. I'm presuming, Lawrence, you haven't had any therapy so far, right?
No, none. And no biopsy either. I thought for the longest time it was still in the Muggus stage. My oncologist thinks it's Waldenström's, but short of a biopsy, she can't definitively say it's Waldenström's. But it started at 6, and then it eventually went up to 18, 19. But the last 5 years, it's been 19, 20, 19, 20.
Well, that's unusual because usually you'll meet people that have been diagnosed. They have a certain IgM, and that's been the IgM they've had all along. The fact that yours went up and then stopped
Mhm.
That's very interesting. We always ask people about other medications they're taking or supplements that they're on. Is anything, and I don't want you, here, to tell us anything about your other meds or supplements, but keep that in mind. I've had people who have gone on supplements who, seem to curiously, have their disease sometimes go into a remission with some supplements. I had one gentleman, I'll share you this story. It's a really good one. It was somebody was diagnosed with Waldenstrom's, and it took a little while to get an appointment. That was back in the days when I was solo practitioner and no help at all. And it took, I think 2 or 3 months to get the patient in to see me. And when the patient finally came to see me, his IgM was down. And I was a bit surprised. I thought he may have been treated. And he said no. And he was, a very high functioning person. So I was a little bit curious. And in fact, he was no longer anemic the way he had been diagnosed. And so I was very curious. I asked him to come back a month later because he didn't meet criteria to treat. And he came back and his IgM was even lower. And his hemoglobin was even higher. And at this point, I was certain he was under some therapy. He denied it. So I called his doctor. I figured, let me just make sure I'm not missing anything here, because sometimes people do get confused. And his doctor said, no, we were really waiting for you to make the decision as to how we should go about caring for this patient. Well, at this point, I'm really just going crazy, trying to figure out, and we're not talking little drops, big drops in IgM, and big increases in hemoglobin. So I brought them back, and I sat down with the patient. I said, I got to understand what's going on here. I've just never seen this. And after a little prompting, his wife actually gave him a little prompt. And, I asked if he was on any new drugs, medications, supplements, and she gave him a little, jar. And she goes, well, tell the doctor. And I was like, well, what is it? Tell me. Well, he goes, after I was diagnosed, I wanted to get my mind off of Waldenstrom, so I asked my doctor for a prescription. Now, he's talking about his primary doctor. I asked for a prescription for Viagra so I could get my mind off my disease. Well, I said, my first response was, probably not, but let me check into this. And of course, the time course fit this very nicely. And we looked at other patients in our group of patients who were on Viagra. And sure enough, we did see a few people who had their IgMs regress. And so at that point, we did a clinical trial. We went to Pfizer and we said, we'd like you to give us Viagra so we could do a clinical trial on cancer. Well, they were thrilled because, any notoriety beyond just erectile dysfunction was something they were very excited about developing the drug for. And we did the trial. It was the fastest accruing trial we've ever had. In 14 days, the entire trial was enrolled and we had a waiting list. But I'm going to tell you, we were able to validate that observation. And we did do some basic science studies that showed that Viagra did have anti-tumor activity. So did one of our colleagues in CLL. They showed the same thing. But what the trial ended up showing us at the end of the day was that the benefit was relatively short-lived. It was on the order of a few months' time. It wasn't a sustained response. But nonetheless, it was a real response, which is why we always ask patients about, what other things they're on, supplements they're taking, because surreptitiously, sometimes you could be taking something that may in fact be benefiting you that we still don't recognize. EGCG, which is a green tea derivative, comes up very often. It has tumor activity against Waldenstrom too. And so these are the things that we always ask people about. And I'm not going to out you tonight in terms of what you might be on, but just to keep in mind that these are the things that we think about with a story like yours, just to make sure we're not missing anything.
Okay, now I'm happy to stay the course, but I'm not taking Viagra.
I'm not, like I said, That wasn't, I just wanted to make sure that you.
No, I thought that was cute. Yeah.
Why it is that, you know, we published all this. I got to tell you, it was really funny. In fact, it was a Canadian that I'll mention to you. You know, I gave this talk at the American Society of Hematology. It was about 15 years ago when I presented this, the Viagra data. And, you know, we had about 6,000 people in that room. And years later, I was trying to track a patient who had moved to British Columbia. And I called, you know, we were trying to get the data from the doctor, and it was really very hard to get the data on that patient. Well, anyway, I ended up making a personal call to that doctor, and he popped on the phone immediately. And he says, I remember you from that talk in 2004, he goes, when you talked about Viagra, he goes, and I've always been wondering how that trial ended.
I think Paul Kitchen has a question.
Please.
There's two questions, Steve. First of all, is there been anything of a venetoclax and ibrutinib trial for those who have been previously treated, or is it? I know that you have the trial right now for the non-treated.
Yeah, Paul, I wish we had it for the previously treated patients. We tried to make a hard case to the company to allow us to do that because as long as the patient was naive to either ibrutinib or venetoclax, we wanted to allow those patients to come on the study. They were very adamant against us doing that. Some of the reasons I think are probably commercial reasons. But I would just say that, you know, we are revisiting this. The trial is accruing well, but I do think, you know, the exact question that you just posed, how will we ever know if somebody who's been previously treated may benefit from this if we don't include that patient population? So we are gonna, you know, revisit this with the company. In fact, I know that once Hori comes back from vacation, it's one of our conference call items again to go back to them. And there's 50 patients on this trial, so it's not like we're, you know, it's not like it's a small trial. It's a big trial. So having more patients on there that represent the diversity of previous treatment experience is important.
Good. I wanted to thank you very much for coming on this. It's very good of you, Steve. We in Canada really are delighted that you take the time and make the effort.
Thank you, Paul. It's really my privilege. Alan.
Yes. But Dr. Treon, I have been taking ibrutinib for 5 years. One of the side effects is constipation. Now, my question is there any reason why I cannot take probiotics? Because all the probiotic supplement has a warning saying people with lymphoma should not be taking probiotics.
Yeah. So Alan, I don't want to, you know, first of all, constipation is very unusual with ibrutinib. In fact, it's the other way around.
Yes.
It's uncommon to have diarrhea with it. So I would make sure that there isn't another reason. There's some things I would think about, you know, that for the constipation. But there are other things that we would probably go for, is like colace, which you may not tried, Senecot. Sometimes we do other things that help with the motility of the gut. But I also would want to make sure that the motility of the gut isn't a problem because of amyloid or other problems. So I think in your case, if you have really constipation that has you that concerned, it may not be the ibrutinib, because that's a very unusual side effect, very, very unusual side effect, usually the other way around. And I want to make sure there wasn't something else that we weren't missing.
But in general, can I take probiotics?
Well, you know, there's reasons why there's things that are prohibited. Most times they're prohibited because we just don't know. Okay. So I would be reluctant to make any recommendation, especially over a Zoom call.
Okay.
Does anyone else have a question? I have a question, actually.
Sure.
I'm on ibrutinib, and I have mid-88. I wasn't tested for CXCR4. So would it be still a good idea for me to be tested?
That's a good question. Betty, I think ideally everyone who is diagnosed with Waldenstrom should get both mutations if the facilities are around. In Canada, it was very difficult to get CXCR4 testing, and probably still is. I know Quebec was making some progress. When I was up there lecturing at the different university hospitals, they were able to finally have a center of excellence that was going to do all the CXCR4 testing for Quebec. So I don't know, how other provinces, have fared. But getting it at diagnosis is ideal. But before you start a BTK inhibitor, I think it's very, very helpful. And in fact, the NCCN, which is the board that makes the recommendations for how patients should be treated, the National Comprehensive Cancer Network, and Canada has membership in this too. They do also advise we get CXCR4 testing, because then we can set expectation. Is the patient going to respond soon? Is the patient, going to have a deep response? Is the patient going to progress sooner? Those are things that we might pre-anticipate. And now with what you're seeing, is the patient also qualified for a trial or in the future a therapy with a CXCR4 inhibitor? I do think that's going to happen. We are going to have CXCR4 therapies available for Waldenstrom patients. And so, that will be all the information that we're going to be able to have at our disposal if we have your CXCR4 status. So if you're able to get it, great, because I think it does help the clinician ultimately. Mark, your baby looks adorable. Can we have a look?
Yes, we want to see the baby.
Yeah, let's see the baby. Yay! Very nice. Congratulations.
Look at those award-winning cheeks.
Oh, that's adorable.
What a treat.
Are there any more questions?
Well, I have one.
Sure, go ahead.
It's in a slightly different arena. I have a question about therapy in the age of COVID.
Oh my, good
Is
question.
that acceptable?
Oh, totally.
Okay, so I was about to resume immunotherapy. I'd had immunotherapy 9 years ago, close to soon after I was diagnosed, and that was my doctor consulted with you, Dr. Treon, or should I say Steve, or should I just call you my Sherpa guide?
There you go.
And I did Rituxan. I worked well until it didn't, and reacted badly to it. And then ofatumumab, which was a little better, and I had a 5-year remission. So the symptoms have come back again. One symptom, itch, pruritus, that's it. So my current oncologist, who's worked at with Dana-Farber folks and has consulted with Dr. Castillo, had set me up for immunotherapy in April, and then in May, just postponed it on the day we were going to start because of concerns about my safety, even in an outpatient setting. And so I'm wondering, in a general way, how we can weigh the risks and the benefits of being in outpatient immunotherapy, which I really, really want to do.
Which immunotherapy are we talking about?
Ofatumumab, a low dose, and slowly, slightly graduated upward to handle the tolerance.
Gotcha.
And so I would be in an outpatient setting for days. And so weighing the risk and benefit of that, again, I really want to do it, versus continuing to stay on the various steroids I've been on, which is always a double-edged sword.
Right.
Prednisone, then Kenalog, and now dexamethasone.
So I'm going to put up, I hope you can see this on the screen. Can you see my screen?
I see the buildings.
Oh, good. I gave this talk just recently to the Israeli Hematology Society because they had asked me about, the treatment landscape of Waldenstrom in the era of COVID. And I just want to actually try to advance here let me just get the slide that I want to show you. There have been a lot of deliberations around how to treat patients who are experiencing COVID, which is why I just wanted to take some time and maybe we can just talk a little bit about this. And so some of you may have seen a paper that we just published, which appeared in the journal Blood. And it was a paper about how patients who were on Ibrutinib, who had Waldenstrom and who contracted COVID-19 fared. And in fact, the ones that were all on full dose Ibrutinib actually did extremely well. They had the cough and fever associated with COVID, but not the shortness of breath. They didn't require supplemental oxygen. The one patient who was on low dose Ibrutinib because of joint problems, he had his Ibrutinib stopped, and then after that he became very short of breath, ended up in the hospital, and long and short of it is he became mechanically ventilated, and at that point we put him back on full dose, this time full dose Ibrutinib, and a day later he was off the ventilator. A day after that he was discharged home. So we published this in the journal Blood. We became the first group to actually publish on the potential use of Ibrutinib for treating COVID-19. And other reports have now surfaced. This actually was another paper that just got published just a few weeks ago from a New York group. Again, protective role of BTK inhibitors in patients with CLL. This paper also came out in late June this was it from the NIH, on using acalabrutinib and treating patients with severe COVID-19 in respiratory distress. And they also showed exactly what we had shown, that the patients have marked improvement in their shortness of breath. Now, why do I show you all this is because of all the data that's been generated from these reports that show that, BTK and IL-6, which is a cytokine, a protein released by the immune cells in response to BTK, is all elevated in people who have COVID. And the ones that are actually getting a BTK inhibitor, it all goes down. And they improve. All the COVID patients improve. Their oxygenation goes up. Their markers of inflammation go down with the start of a BTK inhibitor, which is why with these reports, there was a consensus panel that met, and this paper has now been accepted for publication. It's got world authorities on Waldenstrom contributing to this. And there were two questions that were part of this consensus statement. The first one was, should we be changing indications for treating patients with Waldenstrom? This was a very good question because what it basically said is that if your reasons for being treated with Waldenstrom were borderline, meaning that you're mildly symptomatic, then maybe we should wait because the risk of bringing you into the hospital, of exposing you to chemotherapy, maybe might be better served if we just kind of watched and waited you. And look at the bottom here. For patients with anemia and low iron levels, why not even try some iron, intravenous iron to kind of put things off a little bit. All good advice, but in the era of COVID, we don't know when this thing's going to be over. You can't just tell people, please wait and wait and wait and wait. So question two may be more relevant to you, Dina. So question two is, should we change our approach to treatment? Now, I have to tell you, for starters, remember, this is based on opinion. These are all experts. They're all Waldenstrom experts, but it's opinion. We don't have any data to tell us any of this is better than the rest. We know that the BTK inhibitors seem to be beneficial, and may offer somebody the chance to be treated at home and not have to travel to be seen by their doctor. We do everything by telehealth now. So this is a way of compartmentalizing patients so they don't get exposed to COVID. But I think what you see, the other bullet points are even more interesting. And that is that, immunosuppressive drugs, drugs like, Rituxan or bendamustine or proteasome inhibitors like bortezomib, maybe it's best to avoid these and prioritize maybe a BTK inhibitor as an option. And that's what the experts came together in terms of consensus. So right from the horse's mouth, I think this this has been accepted for publication. It may not even have come out yet, which is kind of funny because these things get accepted and, it'll probably come out after COVID is over. So at least now you have a chance to see it.
But there's nothing therapy.
What's that?
But there's nothing per se about immunotherapy.
Well, immunotherapy is, now this is why I asked you about what you meant by immunotherapy, because anything that's Rituxan attached would be considered immunotherapy. Was there something else that?
Ofatumumab.
Well, OFA is Rituxan. I mean, it's OFA is a humanized, more humanized version of Rituxan. Yeah. Rituxan, many of you may or may not know this, is 10% mouse, 90% human.
Yes, yes, I knew that.
Engineered antibody. Ofatumumab is almost all human. Yeah, in fact, it's fully.
Right.
Yeah.
The mouse part didn't like me.
Yeah. So it's very common. In fact, that's what I was showing earlier about Rituxan. I was probably referring to patients like yourself. Okay.
So it's a waiting game, but thank you.
Yeah.
Thank you. Yeah.
Mine, as always, a real treat for me to be able to connect with our Canadian patients. And if there's any other questions you want to run by me, feel free to email. I'm at your disposal.
Thank you again, Steve, for generously giving up your time. We're so amazed at your availability, and we so appreciate it. Thank you again.
Truly my pleasure. Thank you.
Thank you.
Everybody, take care.